Welcome back to BioInsights, where I would like to always say that exercise science meets commercial reality. And I have joining me back again today special guests that I'll get to. But I want to start this discussion with a story. You know, imagine you have an athlete, they broke their arm, the doctor takes an x-ray and points at a jagged white line on the x-ray, and it's pretty clean and simple. He either has a fracture or he doesn't. And this injury and feeling discomfort in some way. And in the prior conversations, we touched this topic of pain. And what I look at it is pain is not simply binary. You either have an injury or you don't. And on a musculoskeletal health side, it really has to be defined a little bit better because we have statistics to really support this. Over about 124 million US adults report some type of musculoskeletal condition every single year. Half the adult population comprises a national cost of 560 to 635 billion. It consumes about 12 to 14% of our health care and in the US. And here's the problem. You can't draw blood and put a vial of pain in the centrifuge. But pain under a microscope, either you can't say that's it. So pain is the most common reason anyone seeks medical care, and it remains completely invisible. So today we're going to really take a dive into pain and look at the nervous system and what constructs it, and we're going to talk about a stub, like basically it's not the same as stubbing a toe on a Saturday and then feeling the agony on a Monday. So what's the clinical evidence that actually says about treating it as well? So my guest today has built his business on this. So if you look at recovery limitations are really not a limitation, they're really neurological. He's a physicist, he's an engineer, he's the founder of NeuFit, whose newbie technology has been used over with 4,000 practitioners, 75 professional sport teams. So with that being said, Garrett Salpeter, welcome back to BioInsights.
Thank you, Marcelo. It's great to be back on. And yeah, this is a very interesting topic. When you think about pain, there's so many interesting things that come to mind. Like, for example, phantom limb pain. If someone has a limb amputated and yet it still feels like that limb hurts, how does that happen, right? There's all these just fascinating topics and misconceptions. And I think that opens up a door to understanding in a way that can really be empowering because it gives people and practitioners, it gives us strategies to use to actually help those in pain.
I agree, and I think you specifically in episode one talked about about this with your college hockey player that got injured, and somewhere between the MRI and the surgeon's recommendation, you as a physicist started seeking a different question of what happened. And, you looked at it, the difference of what happened was in the tissue when it was injured and what happens in the mind. So there are two entirely different types of physiological events. Can you talk about nociception versus pain?
Yeah, that's a good way to start there. So I definitely, as you mentioned, I had this physics undergraduate degree, was graduate school in engineering. So I had this engineering mindset. And when I found from firsthand experience how direct current electric fields influenced the healing process in the body and how working with the nervous system made such an impact, it was a revelation to me. And one of the biggest learnings I had from that is still the underpinning now, almost 20 years later, still the foundation of the work that we do. Because whether you're like me as a college athlete dealing with a soft tissue injury, or you're an amputee with phantom limb pain, or you're someone else who has chronic pain, pain is a response to a perceived threat in the body. So we used to think that the body had pain receptors, and that when a pain receptor was triggered, that signal would go to the brain, and the brain would just passively reflect that signal of pain. Now we know that it has to do with, as you said, Marcelo, nociception, and it has to do with the way that the brain monitors input from the internal and external environments, right? The brain is monitoring millions of bits of information every single second, and it's extremely vigilant. It's oriented towards survival and protection. It's looking at all of those bits of information, every single one, to scan for potential sources of threat. And when threat comes in, that's nociception. So nociception means the signal of threat, and it's sent by different mechanoreceptors, different sensors in the body, and then different nerve pathways. So there's a nerve pathway in, oh, sorry, you're going to say something?
No, yeah. So just to frame it another way, so nociception is just hardware, the raw data transmission, and pain is the software. Is that one way of looking at it?
So nociception is a nerve pathway. So there is a hardware component because it's essentially being transmitted on different cables, so to speak, where the signal, say from a muscle called a muscle spindle, that's sensing the length of the muscle, or different sensors in the joint that sense the joint position. There's different nerve pathways that transmit that information. Then there's another one called a C fiber, which is a nerve pathway that transmits this nociception. So it's triggered by things like inflammation, for example, because inflammation is often associated with damage, right? If there's tissue damage or a muscle tear or something like that, there's damaged tissue, and the body, as part of the response, sends inflammation there to, first to come in, kind of clear out the debris, to eat up and dispose of the damaged material, and then to guide the process of rebuilding and repairing. So that's one of the things that sets off those C fibers, for example. So there is a signal, and then it's not just though that signal going up and then being passively reflected by the brain. It's that signal going up along with all these other millions of bits of information, and the brain integrating, processing, evaluating, and then choosing how to act on that signal. So there's a very important step here, and I think that I'm actually going to read so I get the exact word for word definition of pain here. Pain is the brain's output. So it's not just an input or something that's reflected, but it's an output created by the brain intentionally for a purpose. And that output is an unpleasant sensory and emotional experience. So it has these two components, right? Sensory that we feel and an associated emotional experience that signals perceived danger, not necessarily tissue damage, and it acts as a protective mechanism. So it's a mechanism trying to protect us. So there's an element of future orientation, looking forward into the future and orienting from a place of fear, trying to not do something. It's the brain's way of saying, don't do that, change your behavior for fear of getting injured or making something worse in the future. It's the same reason that our brains create tension to prevent us from stretching too far in case we might get injured. Same sort of thing. And so one of the most interesting components of this is the connection between tissue damage and pain, because sometimes there is a one-to-one connection. You stub your toe, as you said, or you get into a car accident, you have this physical trauma, tissues get damaged, and they should hurt for a period of time. So there's that one-to-one correlation. And because that often is the case, we tend to think pain means tissue damage. But there's cases where, the injury is healed, and even though the injury is healed, the pain still continues on. Why is that? And then there's the case that I mentioned in the beginning of the phantom limb pain, where the limb isn't even there, but it hurts. Why is that? That's a good one to unpack. So it has to do with the way the brain is integrating these inputs, or in the case of phantom limb, lack of inputs, and how that triggers the brain in that integration process to then create this output signal of pain.
Yeah, I think it's basically, so if pain is is a vital evolutionary alarm, basically. That's what it sounds like. It lets us really look at this inconsistency, right? Because we talked about stub toe on Saturday, but Monday it hurts. Because sleep deprived, stressed. That could be mental stress, and so that's a completely different output. So there's a concept called gate control theory. What are the spinal gates and what opens them and what closes them?
So that is a kind of the first real sophisticated accepted model of the neuroscience of pain. It's evolved in the last couple decades, and what the gate theory describes is sort of a hybrid between the first understanding of pain being something that happens in the body and just being transmitted up and passively reflected by the brain. That was the first step, and then the gate theory is the next, and then the more modern approach that we've been talking about is the one where the brain integrates everything and then creates the signal of output. So it's sort of the halfway point between those two ends of that progression. And what the gate theory describes is there is this pain signal coming up from an injury or insult in the body, and then it's gated in the sense that the body has some say as to whether or not it permits that signal to get through based on competing priorities and other signals and things like that. So it does give some element of control over whether the pain signal ultimately gets expressed in our experience or not. So it is part of that progression towards this more modern understanding. And it is aligned with a lot of what we know now. Like, for example, there's parts of the brain in the brainstem in particular that inhibit pain ipsilaterally, meaning on the same side. So there's a part of the left brain, the left brain controls volitional movement on the right side, but it also sends a lot of information, of signal down to the same side of the body to control resting tone and muscles and to inhibit pain. And so there's a strong component of the nervous system and central nervous system, right, brain and spinal cord, allowing or not allowing some of these things to get through and influencing how they're processed. So there still are, at least metaphorically at least, different so-called gates along the way. But I think that's the main sort of pattern that we want to get across, is that of the brain holistically integrating everything that's coming in and then choosing based on the overall perception of threat and in its vigilant state, monitoring that threat, deciding when and where to create that experience of pain.
So what does that tell you about single modality treatments and why they fail?
Well, it depends on what the modality is and what the person has going on. And oftentimes when a treatment fails, it's because it's not giving the person what they need at that moment in time, right? It's because there is a perception of threat that's there for a reason. And I think in order to understand why something might fail, we have to understand the reasons why someone would perceive enough threat there that it would cross the threshold to trigger their brain to create that pain signal. So there's this model called the biopsychosocial model of pain. And the way I like to conceptualize this is something that I've heard in different places that I think is a very effective metaphor. So I like to think of this threat bucket or stress bucket. So imagine you have a metaphorical bucket, and inside of it you're holding all the different stressors and challenges that you experience. And once it reaches a certain threshold, there's a faucet and the output is going to be pain. And so things like tissue damage and injury certainly can go into the bucket, but so can things like disrupted sleep or inflammation caused by drinking alcohol or foods to which you have a sensitivity and reaction. Right? Sometimes people are like, gosh, I ate balsamic vinegar and now I have joint pain, or whatever it might be, or I ate, whatever it is. So there's also psychological, relationship stress, work stress, things like that. And if you think about it, it is very relevant to this orientation that our brains have towards survival. If I see my job as a paycheck that allows me to buy food and put a roof over my head, and I'm at risk of losing my job if I don't perform on this project, then guess what? That stress that I'm feeling about possibly losing my job is relevant to survival, and that triggers these primal, evolutionarily important and preserved mechanisms wherein my brain is going to perceive that as threatening. And if that is enough threat in this bucket, then it can trigger the output of pain. And if I haven't slept well and I have a little bit of tissue damage and poor movement patterns, maybe deficits in proprioception, and then I add this on top of it, even though I don't have a, quote unquote, fear of losing my job muscle, if that is the thing that pushes me over the threshold, that might actually cause pain. So that's a large part of why people often have an ebb and flow in pain. One day they might feel great and they don't really do anything that they think should have hurt them, but then the pain comes back the next day. So that can describe some of this. And I think it's helpful also to think about there's essentially 3 layers of pain. There's the tissue damage, direct one-to-one correlation. Then there's nerve impingement that can happen along the way from the body up to the brain. And then there's the central mechanism, which is what we're really talking about here, which is where it's more in the processing and integration processes within the brain itself. And looking at all these things, I think, if you can understand how treating someone with a TENS unit or just, doing massage or red light may not address everything, or just stretching may not address it if it's a deficit in proprioception or if it's from relationship or work stress, right? You're not addressing the root cause of that person's pain.
Yeah, because acute pain is a symptom, right? But chronic pain is the disease of the nervous system itself. Why does, you brought up back pain, let's say a person has disc herniation, and it's more or less healed, or the inflammation is gone. Do they still have a debilitation in the back itself? And what happened to the nervous system?
This is such an interesting topic. There's very fascinating research looking at the connection between damage to the spine and pain. And it's something, the numbers kind of work out conveniently. It's something like 30% of people in their 30s, 50% of people in their 50s, 70% of people in their 70s approximately have issues that show up on imaging, whether it be a bulging or herniated disc, issues with their facet joints, whatever it might be, have an orthopedic issue that shows up on MRI or X-ray, and yet they don't have pain. So of all the people that are walking around without back pain, that percentage of them have these issues. So there is a big question of why does a disc bulge cause pain in one person versus not in another? I mean, of course, there can be the severity, there can be the recency, how recent it is. There's also this overall perception of threat. There's also their physical load. Are they moving in a way where they're actually aggravating and putting force through that compromised area or not? So there's a lot of movement patterns have to do with it. And then also, of course, the overall stress bucket, right? That's a huge part of it. There's so many factors that go into it with back pain, but it's really interesting. There often is a mechanical issue, and then there's also the interplay of the mechanical issue with all these biopsychosocial factors.
Yeah, you can't separate the brain from or the person themselves, who they are, from the mechanics itself. I think we want to put everything conveniently into buckets. How do we screen for these in practice? And obviously, how does your product NeuFit change the equation for some of this situations that people are stuck in, a cascade of injuries?
There's a few pieces to this. When we're talking specifically about low back pain, there often is one or more mechanical flaws. Like there's great research looking at deficits in multifidus activity, which is one of the innermost spinal muscles that it has a lot of sensors, a lot of sensory receptors inside of it that's monitoring the spine, so it can trigger the coordination of other core musculature to control and protect the spine. There's also often different triggers, like if someone, I myself, when I have time, try to play golf and work with some higher level golfers, and you'll see things like if people don't have enough hip rotation or hip extension, the movement that should be in the hips ends up going into the lumbar spine and irritating it over time. So looking at movement patterns, of course, is a big deal. Correcting any underlying triggers, because in low back pain is very interesting. There's a lot of chronic pain where this biopsychosocial discussion is super relevant. There also is in low back pain a very common pattern where people think they have chronic pain because they've had low back pain for a relatively long period of time, but it's actually chronic, or wrong word. It's actually consistent repetitive bouts of acute pain because they keep mechanically irritating it. So there are times when there is a mechanical trigger, and the work by Dr. Stu McGill, for example, and people like Gray Cook and Kyle Kiesel, they have some really good work here. So I don't want people to go away from this thinking all low back pain is all in their heads, because it actually is very, very common that there's a mechanical trigger that people don't fully identify or understand or address, and so they think it's chronic when really it's just these repeated bouts of acute pain. So that is a distinction that we want to make. I want to make that very clear, because I'm not saying that it's just all in your head and it's all because of work stress, right? However, there are times when the injury, the tissue is healed and there's still pain, and that's why. So that discussion is super relevant.
It's also how people hold stress, right? The muscle responds by tightening and might impinge a nerve, like you talked about, and that is caused from them going into a muscle spasm, because that's kind of what I've seen typically with my clients when I've trained them in the past. Even with myself, I noticed if I did a hard workout and I couldn't do a recovery session properly, and then I'm sitting behind a desk for 8 or 12 hours, what happens, right? So, that's what I observed with my, like, for example, me, like, and I have an SI joint issue. I also have an extra lumbar vertebrae, which a lot of people will probably be like, what? He just say yeah, there's about, I think last time I read it was like 15 or 20% of the population have extra vertebrae here and there, but yeah, tall. I wish I was. I'd be outplayed for the Giants now. No, let's talk about the basically in the clinic floor. When you see that ultrasound is still dominating the clinic floor, how does that make you feel? Even though the evidence doesn't really make it work, I mean, it's still being used, though.
I'd like to start answering that by actually finally addressing your last question, which I didn't even quite get to. You asked like how we would use
your screens,
direct current, and the NeuFit method to help people. So there's two parts to this, and I think this will help us draw a contrast between the approach that I'm a proponent of and something like traditional applications of ultrasound. There can be some benefits, but very limited in the traditional sense. So there's two main parts that I want to look at here. So actually zooming out even further, when someone has an injury, there's two components to it, right? There's tissue damage that may or may not take time to heal, depending on the level of damage and how long it's been. So there's a hardware component, tissue component, and then there's the neurological response to injury, or the software component. And one of the big breakthroughs that I've observed is that whereas so many times people think first and are so focused on and enamored with the hardware and the tissue, oftentimes these breakthroughs come by focusing on the neurological response to injury and finding where the nervous system is bracing and guarding and creating hypersensitivity that leads to perception of threat and pain, where those patterns are happening and being imposed in response to injury, in response to that original insult, right? It's not as much about what happens to us in life as it is about how we respond to it. And when we're working with somebody who's experiencing pain, what I like to do is actually scan around on their body to identify where, sending a signal to actually activate all the different parts of the nervous system and different muscle segments and portions of tissue to find where the nervous system is actually allowing that tissue to work and accept load versus where it's not, where it's actively imposing these patterns of bracing and tension and guarding or inhibition and hypersensitivity, and find those areas and provide signal there as a form of essentially exposure therapy to allow that person's nervous system to begin to bring those areas back online and help improve function, to accelerate what we call neuromuscular re-education. And so many, tens of thousands of times now, people doing this have been able to help a patient or client experience reductions in pain, improvements in range of motion, even when they've had hardware damage or soft tissue injuries, and it's been a breakthrough. So there may still need to be time to let the injury heal and all that, but this will accelerate it, and without doing this, you're going to have an incomplete rehabilitation. So we want to work locally where those neurological patterns are being imposed. We want to go as far upstream as we can to get to the root cause of why people are going to have limited function and why they might experience that chronic pain. And then, in addition to working locally, we also want to work more globally. So we'll do something like our autonomic nervous system reset, work on the parasympathetic nervous system, stimulate that, the vagus nerve, to help counteract the effects of being hypervigilant, help counteract the problems associated with excessive stress, excess amounts of time spent in a more sympathetic fight or flight dominant state. So we want to do those. When you're doing something like traditional ultrasound, in contrast, you're often sending this signal, this ultrasound, this literally mechanical vibrations, sound vibrations into the area with an eye towards increasing blood flow, and there's some value in that. However, you can connect the dots between how the intention there is clearly coming from a hardware-based lens, or looking through a hardware-based lens, coming from that sort of paradigm. You're focused on, you're enamored with the tissue damage where the symptom ended up, and you're trying to help that heal. And yes, there's value in that, but again, you're not getting necessarily towards the root cause, and you're not addressing this whole other half of the entire rehabilitation equation.
I think, kind of brings me to like an understanding of like what are some of the market trends that you've seen with practitioners that have transitioned to newbie, as far as CPT coding or some of the new billing codes that the APTA talks about.
That's a good question, and I can't give a blanket answer because there's a range of applications and use cases and settings and diagnoses for which people are using technology like the newbie. So there's some conditions like neuropathy where using electrical stimulation is considered investigational, not covered under Medicare laws, and so people are charging cash for that. There's other cases where people have all cash practices, and then there's cases where people have entirely insurance practices, and there's hybrids in between. So if people are doing these types of treatments, for the most part, not all the time, but they generally can check the boxes of neuromuscular reeducation, therapeutic activities, manual therapy when we're hooking up our newbie machine to the electric glove and performing manual therapy with the power of direct current in the palm of your hand or in your fingertips. So it's a cool experience. And then there's times where services are either done for cash because they're not covered, or not covered for a variety of reasons, because of the diagnosis, because the plan of care is already complete and people want to go on and do more fitness or wellness sessions, whatever it might be. So there's a range of applications, and it can be used in a variety of ways.
Yeah, I mean, the reimbursement model, I think my point of that question was, it's been so different and so challenged. It's gotten harder over the years because the challenge also is statistically, most people that start rehabilitation programs, if once they feel no pain, they leave you. So they don't fulfill sometimes the whole, all the allotted sessions for them, but then they don't also follow through with aftercare for themselves, even though it's recommended by you guys. So it's kind of like, the concept I always tell, when I was regularly training people was, this is a lifestyle, so if you know that you have this issue, tendon, meniscal, back, whatever, and you've decided to be non-operative, you're going to have to include these workflows or protocols into your lifestyle. And I think that's the hardest thing. And talking to clinicians and therapists right now, what are some of the biggest clinical workflow changes that you see the science demands in application right now?
One thing that jumps out at me that I have heard a few dozen times, which is really cool, is to hear how experienced, effective clinicians who have been in practice anywhere from 10 to 35 years will tell us, hey, I was already a good therapist, I was doing a lot, and this has changed what I'm doing, changed the way I work, and it's helped in their workflows move earlier and move to a higher priority of focus. This notion of looking at the neurological response to injury, of doing a mapping process, for example, to find where the nervous system is imposing these patterns in response to injury and trauma. And it's by moving it up and moving this into part of the assessment on session 1 or session 2, it's possible to get very valuable insights into where this individual's issues are, how much of their problem is actually hardware tissue damage versus how much of their problem is more in the software and more about that neurological response, dysfunctional neurological patterning and control. And there's a lot of really great insights that come out of that help guide a more efficient and effective plan of care. So I think that's one of the biggest differences. And then being able to have more aggressive targets for progress within each session, I think, is a big deal. I think there's a lot of times where you listen to this may have experienced, you go into especially some of these higher volume places where you don't get as much attention. There can be an energy or a resonance of just going through the motions, not necessarily expecting to get a result. You're going to spend the time and money and effort to go there. I would like to get some tangible result each time I go. And I don't think that is a standard that is generally requested or required or expected in many places. And the ones that we work with are holding themselves to a higher standard. And I think that expectation of the progress and the rate of progress is a big deal too.
Yeah, I have a personal example about that situation. My daughter is a dancer, and she's dealt with typical dancers' injuries, and I've always had to bite my tongue, and I finally found the right therapist that is, not only just treating the pain, but actually looking at the movement mechanics and actually, because you don't get both. You get the clinician that follows standard protocol, band, med ball, and selectorized piece of equipment, sets and reps of approach. Not wrong. I'm not knocking it. Lived it and practice it still. But pain is a contextual thing that we talked about here. So we should be doing things differently, or should be an ongoing evolution of clinical workflows. But also let's take this to a different environment, like for a coach or a personal trainer that's hearing right now. What do they do differently on a Monday morning based on what we've covered?
One area that I think would be worth focusing on, and they may already be doing this, but one is having more of a lifestyle inventory with your personal training client, is understanding some of these mechanisms of pain biopsychosocial model of pain, the threat bucket or the stress bucket, and understanding how the different stresses that they're experiencing outside of their, outside of those training sessions, outside the gym, could be related to pain. I don't want to say that I'm encouraging, personal trainers to diagnose pain by any means or work outside their scope of practice, because I do think there's times where you need to be able to recognize there's pain, there's a problem here, and we need to refer out and have a trusted, and maybe that's one takeaway too, is to establish relationships with local physical therapists, chiropractors that you can collaborate with, because they're not going to train people for the long term after their plan of care is over. They'll send them back to you, but if that person is injured or in pain, they're not going to be a long-term client either, right? So there's a good long-term, we can all act in enlightened self-interest and still refer out and still do things that are best for the patient and still in the best interest of your business too. We don't want to just necessarily hold on to everybody and be like, oh, if I let them go somewhere else, I'm never going to get them back.
As cliche and as this is probably going to label me, people will be like, oh, you're a softie, huh? When I trained clients, I used to use I'm a Star Wars geek. I used to always say that they're my Padawans, I'm the Jedi, and I'm going to show them to be a Jedi. In other words, I'm going to teach them concepts of program design, concepts of training load, concepts of rep schemes based on outcomes, and measure that for a specific training outcome. So when we talk about reframing pain and these changes in the relationship in your own body, that's kind of what we talked about today, is having a better understanding of that, because we can rule out certain things. It's a contact injury. Is it a non-contact injury? Is it slept bad? I've always heard that one. I slept wrong and I woke up and my back is out. And I'm like, there's a whole other reason for that one. So what's your thoughts on that? On that reframe of the relationship in your own body.
In terms of how to coach a personal training client to better understand that, I think having knowledge on some of these topics that we've been discussing here is very helpful. Understanding some of the mechanisms of why things hurt, understanding where it is safe, again, likely in consultation with a clinician, but understanding where you can help people with longer term strategies to prevent pain and injury in the future, and understanding some of these things that we talked about, like the repeated bouts of mechanical acute low back pain that sometimes seem like chronic pain but aren't really, based on the true definition of chronic pain. Understanding ways to help those types of clients, help them understand where their movement patterns are putting more load on the lumbar spine because their hips or their thoracic spine likely, or perhaps it's even coming from somewhere else, but more likely than not, it's something in the hips or thoracic spine, helping people understand some of those concepts in a way that it lands with them. Because I do think there's some people love the sets and reps and progressions that you're talking about there, Marcelo. Some people may just have the mindset of, hey, you're the expert, you just tell me what to do and I'll do it because I'm focused on this other area. But even those people who are less interested in knowing the intricacies, even they, I believe, are motivated to continue doing something if they understand how and why it's really working. If they understand enough where it really resonates with them and they understand have a sense of purpose behind it, I think they're much more likely to stick with it and to stick with you.
That's where technology, I think, today is going to be a game changer on the training floor, because you have potentially technology out there and AI, and I'm going to shamelessly plug, let's say, the company I work for, Tonal, to measure that. You could work within a range of motion, power. It's longitudinal data. There's so much you can gain from that. Really, the one thing that I think today really explains it well is pain is not in the tissue. It's the translation. It's the translation that's modifiable. It wants to go deeper, if you want to go deeper, check out Garrett's book, The NeuFit Method on Amazon, and his podcast as well, The NeuFit Undercurrent of and Connect with NeuFit.com. There's the book. And I really want to thank you again, and everyone that's listening. Keep questioning the physical information out there around you about the technology, about the methodology, and keep exploring these mechanisms that we have inside of us. See you next time on BioInsights. Thank you, Garrett.
Thank you, Marcelo, and thank you to the insight seekers out there.